Welcome to We're on ECMO, a video series for the ECMO community. Joining me today is Dr. Brian Bridges, Associate Professor of Pediatrics at Vanderbilt University School of Medicine, PICU Director and ECMO Director of an ELSO Platinum Center of Excellence at Monroe Carell Jr. Children's Hospital at Vanderbilt. Thanks for joining us today.
Thanks, Neil.
Appreciate you being here, and I'm going to jump right into it. I know that in the past, you've also been a contributing author on the topic of anticoagulation for the ELSO Red Book. And I wanted to ask you today, what are some of the biggest challenges you face when managing anticoagulation in an ECMO patient?
Sure. Well, thanks, Neil. I think it's probably one of the most challenging parts of providing ECMO support. If you look at the first ELSO meeting in '89 and the ELSO meeting we're about to have in Seattle, anticoagulation is still an important and hot topic. I feel like anticoagulation on ECMO is like talking about politics. Everyone has a strong opinion, but very little to back it up.
Mm-hmm.
And so, I think the holy grail, I think, for people who provide ECMO support, if you're like me, I have the privilege of providing ECMO support for neonates, children, and even young adults. It's such a wide variety of disease processes and underlying etiologies of need for ECMO support. And I think probably the biggest debate now is, what kind of anticoagulation to provide, to provide that holy grail of how do I keep my circuit from clotting and my patient from bleeding, right? That's what we're all searching for. And I think if you're looking for that holy grail of anticoagulation, unfortunately, there is no perfect anticoagulant.
Mm-hmm.
We are a program here at Vanderbilt Children's who founded in 1989. And, so that we've done a lot of ECMO runs, over 1,500 ECMO runs at this point, and almost all of them have been with unfractionated heparin. Mm-hmm. Fractionated heparin is really old. It's been used for over 100 years. It's not perfect, right? It's, you have problems like heparin-induced thrombocytopenia, which luckily in my pediatric population is really uncommon, but for my adult colleagues is quite a bit more common. Up to 5% of adults exposed to unfractionated heparin will develop HIT. And then have the challenge of my heparin only works well when it combines with my patient's native antithrombin. So it accelerates the action of the patient's native antithrombin 1,000-fold. Antithrombin is what keeps you and I from clotting in vivo as we sit here. So an easy way to say that is if my patient doesn't have adequate antithrombin, their heparin won't work. They will be refractory to heparin. Mm-hmm. We have, over the years, developed a really sort of regimented anticoagulation protocol, and we titrate unfractionated heparin based on an anti-10A, or some people call a heparin assay, a functional assay of what heparin actually does for an individual patient. We did this in coordination with our pediatric hematologist several years ago, and I think no matter where you're at in doing ECMO, I think it's really smart to get the expertise of your anticoagulation hematology experts. With a really careful, consistent anticoagulation laboratory protocol and heparin titrated by anti-10A, we actually produced a couple of papers, and we've actually decreased hemorrhagic complications. We actually decreased the amount of packed red blood cells we transfused into our patients by more than half. And we actually, a more recent publication showed that we have an associated decrease in mortality in our ECMO patients. That without really changing any of our ECMO equipment. Mm-hmm. We've had some great advances in ECMO equipment as of late, in our centrifugal pumps, and obviously newer and better oxygenators, but we showed that difference before any change in equipment occurred. I think my friends in the cardiac ICU, and especially my friends who do VADs, are really excited about what a lot of the adults have been doing for a long time, which is a direct thrombin inhibitor. And most ECMO programs using direct thrombin inhibitors use bivalirudin because of really short half-life.
Mhm.
Some places are using argatropan, which has a somewhat longer half-life. I think what makes these really attractive is that, this would be the go-to anticoagulant for a patient with either suspected or confirmed HIT.
Mhm.
And the nice thing about a direct thrombin inhibitor is that it's not dependent on the action of antithrombin. So if your patient is depleted of antithrombin, either because they don't make enough because of liver insufficiency or because they lose too much through, let's say, chest tube output or peritoneal drain output, it doesn't matter. The direct thrombin will still work. I think the challenge, my friends who have so much success with a direct thrombin inhibitor like bivalirudin, they see the success on VADs, see kids sitting there playing video games on a VAD and doing really great with a direct thrombin inhibitor and an antiplatelet. And for reasons that really disappoint me, unfortunately, that same success we haven't really found replicated on especially our neonatal and little baby ECMO patients.
Mhm.
I think the challenge becomes that obviously ECMO and VADs aren't the same. ECMO has an oxygenator. We clamp off ECMO to trial patients off. And bival doesn't do really great with static flow or clamping. The extra sort of I think challenge is now that we have lost our pediatric oxygenators, we actually require more anticoagulation rather than less. I hope to get the pediatric oxygenators back really soon. But right now, even the patients that we've tried to use bivalirudin in, when it comes to clamping them off, we often have to add heparin. So you're faced with the prospect of using two anticoagulants. And even ECMO programs, pediatric ECMO programs that are really enthusiastic about bivalirudin often find themselves adding heparin when it comes to clamping trials. I think the other thing that really makes bival challenging in neonatal and infant patients is that most places use PTTs to titrate their bivalirudin and their direct thrombin inhibitor infusion. PTTs are notoriously unreliable in neonates and little babies. And add on that things like CRPs that are elevated artificially prolong PTTs, and patients that are deficient in factor VIII artificially prolong PTTs. So there are a lot of things that affect PTTs. Some programs are using different assays such as dilute thrombin times and anti-2As to titrate direct thrombin inhibitors. However, those are not widely available. But I think when we get better measures of direct thrombin inhibitors and what they're actually functionally doing, I'll be a little bit more enthusiastic about using direct thrombin inhibitors in small babies.
Mhm. Well, I really appreciate all that information. I know, like you said, it is a hot topic, and you could get a lot of different opinions and thoughts on it. But I appreciate someone with your experience and expertise being so generous with your time to share your thoughts on the subject. And I wholeheartedly believe that engaging in these sorts of conversations, especially when there are these differences of opinion, having these conversations is ultimately going to lead to better patient care and outcomes. And so I appreciate you taking the time to do that. And as someone who lives down the road from Vandy Children's, I just want to say I appreciate you and all that your team does for the community and beyond. And so thanks again for joining us today.
Thanks, Neil. I really appreciate it.
Yeah. If you're watching, we're on ECMO today, and you have a question that you would like to hear answered by an experienced ECMO professional, make sure you contact me, Neil, Neil, at ECMOadvantage.com. Thanks.